All right, can everyone hear me? All right, I'm going to go ahead and jump back in. It's it is 1:02. Is everyone on Zoom able to hear me again? Are we connected back in? I'm going to assume that's a yes. I hope we're okay there. All right, everyone get some fresh air, at least most of you. All right, yes, anyone outside? Is it nice out there? Okay, good. All right, don't go into a post-lunch coma on me. Heather and I are going to do the 1 o'clock talk. So that's always a little bit of a rough place to be. But we are going to walk through the way we originally titled this was kind of LIC Teaching 201, sort of building on what we talked about this morning, which were kind of the sort of fundamentals of what the LIC is, and taking this sort of to the hopefully what feels like the next level in terms of strategies. What's a little bit different is how we came about putting this talk together. So we're going to try to take you through an evidence-based approach to adapt your precepting to the LIC model. However, the evidence for this really comes from our own people. So Heather, myself, and several other faculty in this room, students, will acknowledge everyone who was a part of this work at the end. Spent quite a bit of time right in the middle of the pandemic. Our timing wasn't awesome. Pulling together focus groups and asking sort of the fundamental question, what is a great preceptor from the student perspective, from the faculty perspective, and then with all of that qualitative data, looking for the themes and trying to really distill what's an ideal preceptor. So we're going to try to bring that to you through this talk, and through that help you develop what we think are impactful LIC feedback and goal setting strategies. Help you develop your student so that they can be autonomous and grow in their skills, and help you really meaningfully integrate your students into healthcare teams and empower your interprofessional teachers. These are all things we've been talking on. So hopefully this just feels like some really tangible tips. We'll include lots of quotes from our focus group so you can hopefully hear the voices that we spent a lot of time listening to that I think were really powerful. So our methods to do this work were to create focus groups from two of our long-standing LICs at Denver Health and our Colorado Springs branch. We had 5 student focus groups that met, comprised of both MS3s and MS4s, so those in the middle of their LIC learning and those who had finished it and had a chance to look back. And then we had 8 faculty groups representing all of our core specialties. These groups in the faculty were divided up by specialty so that they could really dig into what made their specialty teaching unique and what was really required to teach effectively in that field. So these are our themes that we're going to walk through. I'm not going to spend a ton of time on this slide, but just put it up here as sort of a roadmap, and we'll walk through each of these. Goal setting and feedback. Being cognizant as a preceptor of the LIC learning trajectory, creating a shared map with your student of what those longitudinal markers are going to be across the course of the LIC year, how to maximize your teaching in between sessions with your student, how to integrate your student into your healthcare team, and how to support your student in developing longitudinal relationships with patients. I'm going to take the first 3, then hand off to Dr. Cassidy. So goal setting and feedback, as described by a student. I think the best relationships in the LIC are built collaboratively. So you set a foundation of baseline expectations, and we can build on it from there. And we can customize things because that's the advantage of having one-on-one relationship for a long period of time. You tailor the specific circumstances and needs of that learning environment. So thinking about this a little bit more tangibly, this is kind of how we've distilled this, I think drawing on our experiences as well, having taught in this model for a long time. The model most of us are used to working with in a block, I think, has sort of a beginning, a middle, and an end. We've talked sort of about this in Ty's presentation as well. When you actually sit down and do these meetings, day 1, you tell them what your expectations are, and then midway, there's kind of a check-in, and then at the end, you tell them how they did, and then they're off. I think one of the really nice things about the LIC is that it builds in more of this flexibility. So the expectation, and really I think what you'll find sort of happens naturally and organically, is that you'll have the opportunity for more frequent and dynamic interplay with your student. They'll set goals and you'll give them feedback on that. And then you'll give them feedback and that'll help them build new goals. And so this kind of cycle is happening all the time, hopefully every day, maybe multiple times during the day. We've talked a lot about self-directed learning and the growth mindset. So those goals should feed into their self-directed learning. They have a goal, coach them on what they need to know to reach that goal. Students always should be thinking about what they need to grow and what they need to do to reach the next level. None of us have reached our full growth potential, right? We can always do better in our work. So it should never be what are our deficiencies, what are you lacking, but rather what can we do to help our students reach the next level. One thing we haven't talked a lot about is the structure that sort of happens behind the scenes administratively. So each of the students will meet with their LIC director 3 times during the year to review assessments that they've received. So you all are filling in all the data, all these little pixels, as Dr. Loxbizer described. The LIC directors are taking all of that information and reviewing it with the students and helping them distill what should your goals be, where are you really excelling, and where are those growth opportunities so that you can move forward. You should expect as preceptors for the students to bring those goals back to you. If they don't, you should ask them about it. And then hopefully you can adapt your teaching. So if a student comes to me and says, I'm really working on my musculoskeletal exam, for example, then I can say, okay, look at my schedule. I've got a patient who's coming in and their chief complaint looks like knee pain. So that's yours. Let's go work on that. I'm going to watch you. I'm going to teach you. I'm going to help you reach that goal. So that's interweaving the students' goals and my teaching and my feedback. So what we came to understand from these focus groups is that both our students and our faculty think about kind of micro goals and then macro goals. So the micro goals are kind of these little benchmarks along the way that they're hoping to achieve in the really short term. So these are the daily goals. One tangible thing you can do, we talked about this earlier, is start each session sort of with the open-ended question of what are you hoping to get out of today? Do you have any specific goals, anything you're hoping to work on today? And then use that to guide your direct observation. So in the example I just gave with the knee pain, they told me they wanted to learn something about the musculoskeletal exam. I found them a patient. So I may not observe anything else in the exam room because I got a lot going on that day, but that may be the one priority I make sure that I'm in the exam room to watch them do that knee exam. And then I can give them targeted feedback about that one thing. I don't expect to have that take more than a couple minutes each. So one preceptor described this as, I'll ask students when they come in for their shifts, what's something you really want to focus on today? Just kind of set an intention for that time. Macro goals across the arc of the year. I think that's sort of the long game. Have like a visual or an idea of what you expect that student to look like. We're going to help you paint that picture. We actually, through our EPAs, have a very clear idea of what we want that student to look like, right? So what skills does a student have between where they start or where they get to mid-year or almost toward the end, where it still is that delta that they need to achieve to get to that end of year point? And think about different types of goals. It's not always just the specific clinical skills. Those are often the most tangible when we're teaching. Your differential needs more things on it. You're not very good at setting agendas. Those kind of things can be very tangible. But think about things more broadly also. What is unique about your specialty? Remember, you've got this whole cadre of preceptors that you're sort of team teaching with to create this doctor in front of you. So what's unique about what you bring to the table that your student may not see with their other preceptors? This may be unique procedures, certain exams that you do, or certain exams that you order, certain diagnoses. There may be skills that are really unique to your specialty or that you're really good at or that you love to teach, EKGs, procedures, certain physical exam, or knowledge-based goals. You may identify something that's totally appropriate as a gap. Wow, you don't know much about heart failure. So I want you to read about this, look up the evidence for this and come back and teach me about that next time so that we can make sure you fill that gap. So micro and macro goals, again, should be in tandem with your micro and macro feedback. Micro, link to your daily goals and link to your targeted direct observation. Macro feedback is a great time to reflect with your student on their progress made and to reflect on the progress to be made. So two sort of different ways to approach this, but these should sort of be woven together. So again, some quotes from our focus groups. In terms of micro feedback, a student says, good preceptors at the end of the day would summarize what I did well, what I need to work on, and what we're going to do next time, ultimately where I should be by the last session. Another student says, I think preceptors would be surprised how even just the commitment of a few minutes of conversation can make a huge difference. I'm talking about less than 5 minutes of feedback can just be huge. Those moments really add up. So I think this speaks to the same thing we're talking about just getting into the room, just giving them a few minutes here. This doesn't have to be a commitment of 30 minutes at the end of each session to sit down and review everything. Just sort of on the spot, targeted feedback about their goals really makes a difference. The more macro feedback, as described by a student, I'd say, I'm really struggling with making a specific plan even this late in third year. And they'd be like, well, actually, this is what I've seen throughout the whole year. This is where you started, and this is how much you've grown. For me, that was super helpful because it kept me pushing forward and also helped me realize the progress I've made. And then it would help me zero in on where to go next. And with it, what goals I need to set next. This actually makes me think, I was having a great conversation over lunch in the Zoom room, and one of the discussions we were having is how similar teaching our students is to parenting, and I think about that actually all the time. And one of the sort of observations that was made is that one of the more effective parenting tools is, instead of just saying good job, good job, good job all the time, is to just make the observation of like, wow, you couldn't do that last week, as our kids develop and grow. And that just like totally resonates with me when I think about this type of feedback, to say to our students, rather than great job with that procedure or great job with that exam, to say like, wow, you couldn't do that the last time I saw you. That feels like really a meaningful way to mark these kind of micro steps forward. So the next theme that we'll highlight is precepting cognizant of the LIC learning trajectory. So remember, our students are taking this sort of long journey with us, which is really challenging to sort of grasp and get our heads wrapped around. It's even harder for our students to get their heads wrapped around. Rather than a 4-week course where they're fully immersed in a specialty, they know exactly what they need to do, what they need to study, and what they need to do to pass the test at the end of it, right? This is much more intangible and much, I think, more challenging for our students to really grasp and feel like they're making progress. So an LIC preceptor says, for this first quarter, let's work on history gathering and exam. And then the second quarter, we'll work on doing more and more and more differentials. And then we'll start doing more and more detailed plans. And so I try to remember to have an even flow as the year goes on, where I'm changing my expectations. So to me, this is like a super experienced, amazing preceptor who already gets it. We start kind of easy, start with sort of basic skills and build from there. So we call this building blocks, where you start with kind of basic early skills. Your students should come to you with these early building blocks. We have a whole first year curriculum built around clinical skills. So they should know how to take a history. They should know how to do a physical exam. They should be able to do basic reporting skills, tell you in an oral presentation or in a note what they found. That allows you to, once you've established that, move on to kind of the next level of skills. How do you turn that into a differential diagnosis and creation of a plan throughout the year? I really want to emphasize this direct observation. This has been mentioned a couple times. Ataya also talked about how she does this. You do not need to be in the room watching an entire encounter. Nobody has time for that. We just don't have time. And I think the students actually don't love that either. So my strategy has been to try to watch the students at least once a day for a minute or two doing something, and write down 3 points of feedback. They can be good, they can be bad, but 3 things that I can tangibly tell them about something. So I really like the way you developed rapport by asking this question. I really like the way you set the agenda. but you took your sort of back on the patient when you logged onto the computer. So I want you to work on sort of that ability to maintain eye contact when using the EMR. That's 3 tangible things I probably could have gotten in like the first 10 seconds. And then I can leave. And the next time I come in, I maybe just pop in midway when they're already talking to the patient, and I might get 3 very different things. So if I do that over the course of the year, I have a really good idea of how that student's progressing. So interleaving was another kind of sub-theme in this area. So this sort of speaks to the concept that our students are doing a lot of different things simultaneously. And so this is part of the challenge for our learners and sort of the challenge for us too. So I'm hanging out over here in internal medicine, seeing my student every single week in my little bubble. And it's hard for me sometimes to understand what else they're learning and what else they're doing and what else their challenges are as they try to assimilate all this information. What we know happens from the literature and what happens every single year, and I have to remind myself of this, is that there are setbacks early in the year. So this is described in the literature, and I now have to like remind myself of this every single year, is something called the J curve. So students start off coming out of their clinical skills course with all sorts of confidence and skills, and then they get worse. And part of that is because it is really hard to try to learn. The cognitive load is enormous as you're trying to take all the information you're learning from this place and that place and pull it all together into something that makes sense. And so the students get, I don't know how else to describe it, but just like frazzled and discouraged. And they struggle. And I think as a preceptor, it's really hard because they'll come back to me a week later and I'll be like, oh God, we talked about that last time. I know you're bright and I know we're working hard on this, but why aren't we making progress? And a month later, like I still feel like we're not making progress. And the students feel that really palpably too. And so I look at this J curve. I actually have this printed off in my office to remind myself that it always gets worse. You all met Shanta Zimmer yesterday. She's now gotten in the habit of every single year when I come in, as you know, when I was working in my role as an LIC director, being like, oh my God, this is so hard. She's like, no, you're just at the bottom of the J curve right now. Like, I think the directors go through this too. So remember that it's about 4 months in when students hit the bottom of the J curve, but then what happens afterward is the magic of the LIC. Everything comes together. The interleaving is then what works when the students start to make connections between all the different specialties, and the abdominal pain that they learned about with me suddenly makes sense because they saw it in the ED too, and they can make connections to how that relates to the pelvic pain that they saw in GYN, and everything comes together and they retain it in a way that you never would if you just done internal medicine in the beginning, taken a test and hadn't revisited it. So this is how it works, and it works every single year the same way, even though I forget it every single year. This J curve is, I think, really important for us as faculty to remember as we sort of go through the curve together with our students, and really important to reassure our students about. Of course, I'll emphasize again, if you ever are worried your student is in a deeper curve than most of the other students, ask us. Bring that concern forward so that we can help assess that and determine if that student needs additional support. So the LIC is a team effort. I think this is the other piece of this. You are just one piece of this puzzle that's coaching the student, helping them move forward in their year. So an LIC preceptor says, I remember feeling a lot of pressure to be all things of my specialty to my LIC students, and acknowledging that medicine happens in a variety of different settings, and they will get many different perspectives on many conditions, and you don't have to be their single point of understanding for every single condition. This is great advice. It can feel a little overwhelming. I'm the only person teaching them internal medicine. No, of course not. They're going to do internal medicine in so many different places. They're going to see internal medicine on their immersion. They're going to actually see internal medicine pretty much everywhere they go. And so this is part of the kind of village that teaches them medicine. We're no longer thinking about specialty silos. We're thinking about the practice of medicine globally. One LIC student reminds us, even though students only see you once a week, or once every 2 weeks they're growing in between. I think this is a helpful reminder too, that what happens in between the sessions that we see them may be a little bit fuzzy to us, but ask them where they're at and trust that their growth, even though it can seem spotty between when we see them, they're still working really hard, and there's a lot of learning going on in between their sessions. And then this leads sort of to the shared map of longitudinal markers. So I think probably the loudest thing we heard from all of our groups, and I've actually heard it sort of alluded to here, like, how are we supposed to know where the student's supposed to be? You just set us out to sea, and then we're supposed to like arrive at this magical place at the end of the year where the students are ready to be done with clerkship. So how do we get there? So the LIC, an LIC preceptor says, I try to have that conversation ahead of time so that we're both on the same page as we progress. I think that's helpful, just to have the dialogue early on, the plan for progression. So they don't feel like when it's September and they're not getting the plan right, they don't feel defeated. They have an understanding that it's not actually quite yet expected of them and we're progressing towards it. So I think those are exactly the kind of conversations we want to have with our students. We don't expect proficiency in these skills day one. This is like an aspirational thing that they'll achieve by the end of the year. But how do we know, and how do the students know that they're on track? Is September an okay time not to know that, or should they know it by November? One of the big asks of us in the something that came out of this work was the need to create a map to help guide everyone. So as you've heard, EPAs are the activities that physicians should perform independently on day one of residency. Our students roughly progress stepwise through these. They start off as novices and should have proficiency by the time they graduate. So what we aim to do was create a benchmarking document that aligns with all of the EPA domains in which you will assess your student. So we will email out a draft of this document. It is nearly done, but I think it'll give you an idea of what we're aiming for. We will have a final version for you to use before September. I want you to think about this document sort of having multiple uses. For the students, they can look at this and say, okay, it's November. What should I be able to do in terms of my documentation? What should I be able to do in terms of my communication, and so forth? For our preceptors and our faculty, it gives you a clue. Like, where should my student be? Are we behind? Should I be pushing them more? Am I pushing them too much? It also should allow you to identify outliers and red flags. And then hopefully you can use it as a tool when you start to write those assessments. What am I supposed to be assessing my student on? I can't even remember. I just know like they show up here every day. I'm totally blanking. Oh yeah, communication, note writing, professionalism. These are the things that matter. And where is my student supposed to be right now? And then for our LIC directors, I want you to keep this document next to you. So when you sit down and do your assessments and your meetings with students, you can get a sense of like, I've read all of their assessments now. Are they roughly on target, or is this student like way off here and left field, either like the best thing I've ever seen or super far behind? So hopefully it just gives you that holistic sense of where they're at. So as a reminder, these are our EPA domains. There are quite a few of them, hence the length of this document. So I don't expect you to sit down and memorize this thing. It's a reference. This just gives you an idea of what this will come together as. I don't expect you to read the words here, but this gives you, this happens to be our differential diagnosis domain. So it'll give you a list of what we expect a student to be able to do in September, the day they start the LIC, where they should be roughly in November, where they should be in April, and what they should be able to do in terms of creating a differential by the end of the LIC in August. And so you can flip through this document and see in every single domain roughly where our students should be. This is the kind of benchmarking we hope will be helpful to decrease some of the anxiety and worry about whether we're all on track as teachers and as learners. Okay, I'm going to hand off now to my colleague and partner here, Dr. Cassidy.
Hi, everybody. So I know we're kind of in the middle of a talk, but I actually haven't had a chance to introduce myself yet. So I was going to just pause here. No, it's okay. And because I'm going to be with you for the next end of this talk and for the next one. So I just wanted to let you know who I am. So I'm Heather Cassidy. I'm an LIC director in our Colorado Springs branch. and I'm also the Assistant Dean for Community-Based Medical Education. So I try to support our community-based education programs and our community-based faculty wherever they are across the state. And so I had the chance to have lunch today with several of our preceptors in our rural LIC program who flew in or drove in from the Four Corners and Durango and Carbondale. So thank you. That's a big trip, and we appreciate that you're here. This work has been really fun for me. I've been in the LIC since 2016, and I started in Colorado Springs in Kaiser's model and precepted as a LIC preceptor at Kaiser for several years. And now I'm actively, I'm a civilian on an active duty Army base in Colorado Springs at Fort Carson. And so I do veterans care there, veterans independence at Fort Carson, mainly geriatrics. So that's sort of the lens I come to as an LIC preceptor. So Jen told you a little bit about methods here, and I'm just curious, I know some of you obviously from LIC leadership, but do you mind raising your hand? Who is new to precepting in an LIC this year? Because I know we've got new LICs that are rolling out. Okay, who has been precepting in an LIC for a while? Okay, and anybody who's getting ready, like the LIC is coming for you in the fall. Okay, great. All right, that just helps me. We got a pretty mixed audience, so we got a lot of knowledge and kind of places where we are to share. So Jen explained that this is data driven. These are focus group data that we have to share with you. And so one of the big themes that came out of the focus groups, and we heard this from students in LICs at Denver Health and Colorado Springs, and we heard it from faculty, is that really making use of the intercession is important for effective LIC precepting. And what I mean by that intercession is the fact that if you are precepting in an outpatient space, or you're a surgeon and you're precepting on an LIC, you're not in their 1 week, or 2 week immersion, but you're on this kind of weekly flow, you may not see your student for a week or two, or maybe more. So I've circled up there, week A, family medicine, Tuesday. Not going to go back to family medicine, maybe, if you're not in a fully integrated model, like in some of the rural health settings. You may not be back there for another week. So how do we make use of that time, right? The student's learning, Jen just told you, does not stop when they're not around you. And the patient's story does not stop either, just because the student has moved on to another half-day clinical experience. So how do we actually start to not feel limited by the fact that the student's only with us for a half a day a week, and actually feel like that's something that we can adapt and make use of? So that's what we mean when we're talking about intercession teaching. Uh-oh. What did I do? All right, there you go. So the first thing I would say is use that intercession time for clinical teaching, right? So you guys came up this morning when we were all around the room talking about trying to help students identify things that they needed to learn. One of the most effective strategies that the students told us about was when their preceptors helped them identify their gaps in clinical learning, and they use that week-to-week time as a time for the student to keep learning and pressing on that gap. When we help them kind of identify that gap, and rather than just sort of going, ooh, AFib, I don't know, I guess I got to look up AFib, we help them hone in to what they do and don't know about it and identify that piece as a clinical question. So for example, actually, you knew a lot about AFib. You just diagnosed it by listening to their cardiac exam. You know that you need to make a decision about anticoagulation, but what you don't seem to know is how to make that decision. That's what you're going to tell me about next week. What I will also say, though, is the students say that it only works if the preceptor asks them about it again next week. So don't forget that you gave them an assignment. Otherwise, they don't really feel like they have that accountability. But they said that they love this. They love teaching back to you and showing you what they've learned. So use that intercession time to push them to keep learning. I'm not going to read all our quotes. Can you guys read them? I'm just going to pause and let you process. Give me a thumbs up, anybody? Okay. So we can also use intercession time to continue doing feedback. So you guys have heard a lot about feedback today, about what makes effective feedback. And one of the big things that Dr. Loxpeiser said is that it's timely, it's in the moment. But here you just had your half day and it got really busy at the very end. And now you're not going to see them for a week. So it can no longer be in the moment. And by next week, you may have forgotten and you're busy again. And the student has actually also no longer really thinking about that encounter. But students tell us that they feel like feedback in the LIC can be an ongoing dynamic. You might have a chart tool. You definitely have their cell phone number. They don't care how they get it. They're just excited to get it. So if you don't have a chance to see that note till later, you can still send them a little feedback through the chart, a little feedback through email or a text that says, I saw what you did. Here's your tweak for next time on that, note that you did. So they are not necessarily expecting that the feedback stops that day and doesn't happen again until next week. They actually felt like they could continue to correspond with their preceptors. I had a preceptor who would email me after each session about my notes, and they would do a list. Here's what you did great. Here's what I would have changed or done differently. And it was really helpful for me to understand where I could improve with my note writing. The preceptor would say, let's talk about these patients that we saw last week, and now how can we apply this to this week? So this is, again, that interleaving concept of the fact that the learning is just going to continue to layer, and you can pull back to what you guys did before and really actively show that to them again the next week and ask them to take it a step further. And then this is the big one, and we're going to spend a whole hour on this from 2 o'clock to 3 o'clock on really how to make the patient panel experience come alive for students. But I just urge you to remember, I think most of us train in a block model, and our continuity that we got, if we got it at all, was typically in inpatient acute settings where we rounded on the same patient day by day by day. I don't know about you, but I trained at this institution 15 years ago, the last time it did a big curriculum reform cycle, for what it's worth. And if I saw somebody more than once in an outpatient setting, it was a pretty special thing that I got to see them twice in a month. But we all know that the patient story doesn't end at the end of the visit. They're going to have an intervention potentially. They might have follow-up. They might have labs. They're certainly still trying out what you just told them about. And so the learning for that student doesn't need to end there too. And I think that's one of the things that I'd really like you to take home when you think about continuity in the LIC is this way that we're trying to activate the students to not have their learning siloed in their half day with you, but to really be immersed in it no matter where they are. So you can forward them results. You can send them a text message with a picture of the x-ray, no patient identifiers, and say, what do you think? You can ask them to check in on that the next day and send you a message with your thoughts on what they think their plan would be and ask them to then move that forward and call the patient with it. So their learning doesn't all have to happen in the time that they're with you by what you've asked them to learn for themselves, like anticoagulation for AFib. And their learning doesn't all have to stop with the patient or only occur in the half-day increments that they're with you. Really encourage you to start thinking about assigning them explicit patient care tasks that you do want them to follow up on. And I will say that this is a place where we have sensed some tension sometimes because it is different than the way most of us trained. And so in Colorado Springs, sometimes we've had students say, I'm trying, but the preceptor says that part's not my job. And we want you to kind of think that maybe not with every patient, but with some of them, we want them to embrace this as their job. And so I want you to push yourselves a little bit in the comfort level you have with where you can challenge the student to take on that active role. So she would give me assignments. If she was getting a message from one of the patients that we'd seen together, she'd say, why don't you write back to this patient about their lab results and what it means and what their next steps are going to be? Obviously, you're going to talk with them maybe a little bit about it first, make sure that they have the right plan, but that you can empower them with that in this interweek time. A quote from a student and from a preceptor about harnessing intercession time with follow-up phone calls. So the next thing we're going to talk about that was a big theme in the focus group data was the way that we actively and intentionally integrate students into healthcare teams. You guys have already talked about this just by all the great ideas you brought up. So mainly I'm here to tell you that this is reflected in our student and faculty data about what effective LIC precepting means. Okay, when we ask students, when does it work well? They are saying that when the preceptors are really intentional about bringing them on board in the team, that's when it works well. So if my preceptor was emailing for a consult, they would copy me on the EMR note to the consultant and say, this is my LIC student and she follows this patient and you might see her in the hospital or she might come to that appointment. And so I'm looping her in. And so right off the bat, it was like, you're going to be a part of this patient's care. Let's go. So a lot of this has to do with the concept, and you saw a map at the beginning of the whole LIC 101 of like the whole concept of the LIC is continuity with preceptors, continuity with patients, continuity with your peer group. And so the collegiality and continuity with the team is a big part of that, and it doesn't come out of nowhere. I can't tell you enough how much a simple thing like introductions came up in the LIC students focus group data. They talked again and again and again how powerful it was when the preceptor set the tone with the rest of the team that they work with by making sure that they knew who everybody was. And by doing that in a positive, engaging way, this is our student for the year. This is my student for the year. She's going to be working with us for the year. That if the tone was negative, like, this is a student for you, she's going to slow us down, bear with me. It doesn't set that positive tone, but if they flipped it and really set expectations for the team about how powerful the student's role was going to be, that it went a really long way. We've talked a lot about setting expectations for the students, but the students talked a lot also about how the attending could set expectations for the MA, for the nurses, et cetera, about how to engage and involve the student. What was their scope of practice with each patient? I found it really helpful when my preceptor on our first day introduced me to everyone, and you could tell that they had coached their staff. They're not just a student, they're part of the team. My preceptor communicated to his team that these are my patients, so they knew to come to me with a question instead of waiting for my preceptor, and that really strengthened my sense of ownership, but then also really helped my relationship with these people on the team. Like, they felt like I was a responsible member of the team. This works two ways. So we just had a great question at lunch from the team in Durango about who all can I kind of have the student go with? And my answer from the students and the faculty that we talked to would be everybody. You can match your student with any person on your team that you think they're going to learn from. And I would actually really encourage you to do it intentionally. Plan time for them to work with the nurses and the medical assistants and your social worker and your pharmacist. And one of the ways you can do that is by expanding your mental model of what continuity looks like. So you have a patient who comes in and they're working with you. And in the past, in the old model, like the patient's done with you, you hand them off to the social worker or the pharmacist to do some education, and the patient moves on with you. What if the student moves on with you? Like, what if the student moves on with the patient? And they go through that pharmacy visit and that health education visit. So when that happens, you may not see them again for an hour or two. But what we hear back from them is that they feel more comfortable and invested with all of those other members of the team, and that all of those other members of the team feel more comfortable and invested in them too. And so it has this bilateral development. This is a long quote, but it explains that perfectly, so it's worth a read. Following a patient through their whole visit, if they needed to chat with a social worker who was available or the behavioral health specialist, rather than stepping back like my preceptor would have to, is valuable. I think it helped with patient continuity. I could go back and tell my preceptor, when we were sitting and chatting with behavioral health team specialists for 30 minutes, here's what else came up that we didn't ever get to when we were in the room together. So I think it can actually help the preceptor. It can help with tying the team together, but then you also do get that feedback time with these other team members and get to know what it is that they do or talk about. And so then it's easier to feel comfortable suggesting adding them into your plans or going in and grabbing them and telling them about something because you feel like you've already worked with them before. So this all comes back to this idea that we've been talking about supporting a very active role for our learners and supporting longitudinal patient relationships. The more that preceptors entrust you with responsibility, the more you're going to get out of it. I had preceptors who said, let's get creative with the way that you can interact with your patient panel, even if you can't see them in person. This was in the pandemic. Why don't you give them a call? Why don't you send them a message? So the students said loud and clear that the most effective LIC preceptors were really actively going out of their way to support these longitudinal patient relationships, and that they felt like their role as a student on the team was actively valued. So they said, we love it when a preceptor feels like I actually can contribute because of the way I'm here week by week by week. These are some specific examples that came out in the focus group data of ways that students felt like they could be valuable that were echoed by things faculty said about how students could help. So providing support with phone calls to patients who are isolated or lack social support, advocating for patients in unique ways, particularly as care navigators in a complex medical system, providing extra outreach for patients who are falling through the cracks, linking between primary care and specialty care, even by going to those visits and being kind of the person who's hearing it all and bringing it back to the primary care setting. And then obviously doing some of those bringbacks and teaching. the quote there, I always also emphasize that the student has a lot more time to spend hearing the story from the patient, and I have yet to have a patient who doesn't want to spend a lot of time on their own personal story. I'd urge you to remember that the patient panel is an expectation, not an option. As Jen said multiple times, it doesn't have to be with every patient, but they do need to choose some to go deep in. And what we did hear from the students is that that can be a little intimidating. They want to have those relationships, but sometimes they're like, but I'm just a student. I don't know. I can call them back with that result. Could I really go? Is it going to be weird if I show up and say hi in the hospital? And what we heard is that they need a little activation energy. Like once they kind of get over the hump, you remember your physics, like then they were kind of excited and they were all in, and you can be the activation energy. So when the preceptor says, this would be a great patient for you to follow on your panel, this is somebody that really could use some extra support. Like they've got some danger of falling through the cracks. Then the student was like, okay, I know they want me to do it and they're telling me it's okay to do it. I'm going to go in and I'm going to do it. So you can be that kind of motion and force that really helps them activate into that longitudinal role. We do find again and again in the data that direct observation, even for a few minutes, can help you figure out which patients work for the panel. Like you know your patients well, right? So you probably know which ones are going to love that extra attention. But if you spend a few minutes in the room watching, and it doesn't have to be many, you can often feel that connection between the patient and the student where you're like, okay, this is going to work. They're loving it. You're loving it. Something is working here that we can really build off of. Intentional scheduling is mentioned frequently. So I know we have a variety of different kinds of scheduling models. But if a patient's there on a Tuesday morning, chances are Tuesday morning might not be a bad time for them to actually make it to an appointment. Could they come back on Tuesday morning again next time, in 2 weeks, 3 weeks, whenever it is? And getting comfortable asking that, or working with your nursing team to coordinate it, and then coming back to that intercession concept. So I'm going to pause there, and we're just going to kind of synthesize this all together. Any questions before we dig in? We call this the theory to practice talk, because we're trying to start giving you concrete suggestions after a lot of big picture ideas. Jen started this by saying it's a data-driven approach. This came from an IRB approved study that we did with students and faculty. We were reading the student data first, and we read through hours and hours of student transcript data. And we had a team, and we built a code book, qualitative research. And then we said, oh, now we got to go and do hours and hours of faculty data. And are we going to end up with a different code book? Like, is it going to be different data? Are the faculty going to be telling us different things? And the cool thing in this study is that was not the case, actually. The things that we were hearing from the students matched up very closely with the things that we were hearing from the faculty about what made an impactful precepting experience. So the themes that we've just shared with you, these are things that filtered up from both places, from the students and from the faculty. And the take-home theme that I have is that all of you, whether you've been in an LIC or not, have been doing medical education for a while. I think you're familiar with concepts of feedback and goal setting, et cetera. But I think what we were hearing here is that to do the LIC well, you have to take those concepts and then be willing to just tweak them a little bit, because the LIC's form and structure is different than what we've done before. It's different than a 4-week block model or a 12-week block model. And so if you try to overlay everything you did there and just sort of put it on top of the LIC, it may feel clunky. And I think what we're trying to give you here is a way of thinking about those same core educator concepts around feedback, around using your building blocks, around your observation, and figure out how to do them on the timeline and the learning curve of the LIC. And just acknowledge that that's a different timeline and a different learning curve than what you've precepted in before. This is new to most of us, right? How many of you, when you first heard about an LIC, said, no way, how can a medical student possibly learn that way? Anybody? Like, I see some smiles. Jen says yes. I definitely felt that way. I was faculty at my alma mater at Brown, where I did residency, and they were building an LIC, and I was like, no way. There was so much skepticism. So I just think it's important to acknowledge, like, this is new to most of us, and the tools we're trying to give you here are tools to kind of adapt what you've already known and been doing and trained in and believe in, because we like culture and history and hierarchy in medicine, and figure out how to move it to something that's a little new and different. It is a culture shift for us. And if you take home nothing else, I would ask that you take home the concept that it's not going to happen on its own, and your attitude matters, okay? So we heard loud and clear from the students that when they have preceptors who express skepticism or wariness, or I don't know about this LIC thing, that it makes the students feel a little skeptical and nervous about the LIC. And when they had preceptors who said, yeah, I'm new to it, but I've learned a lot about it, and it seems like it has a lot of potential, that the students were like, all right, we're going to do this. And I've got quotes to show you. Instructors just continually throughout the year expressed their doubts about the foundation or the concept of the LIC. It made a negative and weird energy to start. It's like they already don't buy into it. So it almost seems like they're prepared to not have it work very well. But the preceptors that really bought into model, they were able to utilize it to teach me more effectively. So as you go out and you're in different LIC spaces, if you have some questions and doubts and skepticism, that is fair. I ask that you bring it to the LIC team that you're working with, to your LIC director, to your LIC coordinators, and maybe not necessarily to your LIC student, because we don't want to undermine their faith that they're learning good medicine and that they're going to come out on the other side prepared. We have lots of data, actually, decades worth of data at CU nationally and internationally saying that students will come out on the other side with equivalent, if not superior, academic outcomes, and with actually improved patient-centeredness and empathy. So we've got a lot of reasons to believe in this model, even if it's not necessarily something that we all trained in or feel comfortable with. You heard a little bit about resources. So I'm just going to finish this talk with a little bit of resources. So there's a licguide.org, and you've seen the link a couple times. This is what it looks like if you type that in. This is built from those focus groups. So it is chapter by chapter, giving you high yield tips and ideas built from the focus group data. And the website was developed by Dr. Catherine Ard, who is a alumnus of the Denver Health LIC and is a soon-to-be Denver Health faculty, I believe. Yeah. And then you've also heard a little bit about the CU LIC video. This is a great way to spread the love and the word about the CU LIC. And if you search in CU School of Medicine LIC, you will find it. All right. Yes, questions. Do we have questions in the chat or here? You put up with me after lunch. Is there anybody on the chat, or should we just take a break?
I'll check. This is post-lunch. Questions, discussion, thoughts.
Ellen.
Yeah, come on over to the mic. Thanks. And if there are no questions, we can take another break and stretch and wake up.
Great. Okay, great. Just one question I've been reflecting on through the presentations today is I hear from preceptors sometimes who've been working with students in the clinical year in their third year. How do I need to change my expectations of working with students if I'm working with them in their second year of medical school?
I could take that. So that actually gets asked of me a lot too. And my answer is I don't think we should change our expectations because they're second years as opposed to third years. I have put a lot of faith in David Ecker. Many of you know him. He's the director of our clinical skills course in the first year. It's called Docs. Who in here is a Docs coach? Anyone? Heather? Brandy? Phil? Thank you. So I don't know if any of you want to speak to the curriculum, but I think compared to our old foundations of doctoring curriculum, this is, we intentionally did not try to squish the basic science into 1 year. We redistribute it. We did try to squish the clinical skills into 1 year. So really doubled up on our efforts to get everything compressed, and it's much more intentionally spaced. So they have double the preceptor time, a much more intentional and structured communications curriculum, physical exam curriculum, clinical reasoning curriculum with well-spaced assessments, tons of feedback. So I would venture to say our students are going to be more prepared for clerkships than they ever were coming into third year.
In Colorado Springs, we've been trying to help our faculty disengage from what year the learner is and just say, these are learners in their core clinical year. They're going to be second years unlike anything you've ever seen before. And then we'll learn as we go a little bit. But I think the learning curve we're asking of them is the same. And CU has faith that we are preparing them to be ready the same way we would because of the way we've redistributed content.
Second year is the new third year. So someone says Megan in the chat. We'll just call them clerkships, LIC students. It's gotten crazy enough with the hybrid and the legacy and everything else. We'll just call it. It's too confusing anyway. So we'll just call them clerkship students. Question in the chat. I'm going to punt this one to you. I have wondered if people can really see enough diversity of patients, particularly in racial, LGBTQ plus patients in an LIC, especially in a rural area.
So it's a good question, and I think it depends on each rural area's given community. I will say that we have to remember that our students are going to get another 2 whole years of education back in Denver whenever they come back from their LIC experience. So just like we said, any given half day does not have to be all on you to teach your core specialty. It is also true that the LIC year alone does not have to be representative of all of the patients and populations that they're going to see throughout the course of medical school. So it's possible that they will not, but it's also possible that through the course of other exposures during medical school that they are going to see a variety of different diverse populations.
I would have a similar answer. I think it doesn't matter where you are. There's you're not going to see everything. We've got LICs at Children's Hospital where we have them doing rotations at our other hospitals because there obviously aren't adults there, for example. But they're going to still see fewer of certain patient populations. The LIC, I like to say, is intentionally 1 year long. It shouldn't be all 4 years of medical school. I think it's a great way to build foundational clinical skills and really master with dedicated preceptors and coaching those foundational clinical skills. Once they have that, I think they do need to come back and do different advanced types of clinical rotations and have the opportunity to rotate through different healthcare systems and in more specialty type environments. And that's, I think, where the breadth of patient populations and experiences comes in.
I think there's also been a lot of work by Dr. Frank and by Dr. Kulasakran to build in some of the diversity that might be missing in certain communities into our afternoon didactic programming that'll run throughout the course of the year. So there's places where we're having discussions about all different kinds of patients and communities and how to bring our clinical expertise and communication skills and kind of psychosocial awareness of the way health and society intersect. Like that's all built into each of those cases. These cases were not designed just to be a belly pain case or a heart failure case. They are all exploring a variety of levels of questions and content.
Yeah, another comment in the chat about different aspects of diversity. Some are more visible than others.
Agree.
Yeah.